that can be done for each of these projects. So if you have any questions, do put them in the chat box, and the moderator can interrupt me and ask. And then so we'll just start. So the first is preoperative checklist. I think for those that attended the last session, you may have heard me talk about, something like this, about doing an audit on preoperative checklist. So let's say you're a medical student or a medical doctor or a registrar in a teaching hospital or a private hospital in Nigeria. You may have noticed that before any surgery is done, there are some things that are usually done routinely before the patient is certified fit for surgery. In many centers, there's no standard checklist, so to say. It's mainly based on the experience of either the registrar or the house officers, or the medical students or the consultants, and then they say, do this, do that, do this, do that. But if there was a checklist, for example, as a document or maybe a paper that anyone can just use and take to the patient's bedside and make sure all those things are ticked, then it could potentially make preparing patients for surgery easier for the team. So I'm personally aware that many units do not have preoperative checklists. And the beauty about preoperative checklists is that they can be different for different specialties, for different surgical specialties. So you can have a checklist for neurosurgery, for maxillofacial surgery, for plastic surgery, because all of these specialties have their specific nuances. So that will basically be the background, for this project. So you've identified the problem, which is there's no preoperative checklist. Sometimes patients' procedures are cancelled by the anesthetic department, because something is missing, or the bloods have not been reviewed, or the patient does not have blood bags yet, or they've not paid for a particular procedure, or something. So that's the first point. You've conceived the idea, you've identified the issue. So the next thing is, how do you go about it? How do you influence change and make this sort of audit? Now, I know over the last 3 sessions, we've heard that audits should have a specific guideline test against, and that's true. But there's a sort of overlap between an audit and a quality improvement project, and this preoperative sort of sits right in the middle. So, as a medical student or an early career doctor, the first thing you would probably do is to meet or approach the team or the head of department about this idea. That this is the problem. Sometimes some things are missing and patients don't get surgeries because of things that could have been prevented beforehand, and you want to help solve the problem. But first you have to make sure you identify the problem objectively. After, you have to discuss with the members of the team, because they are the ones that are going to help you incorporate this change when the time comes. So the methodology of this particular project will be a bit different, from the regular methodology. What you do is that you meet all the senior members of your team, all the senior registrars, depending on your level. If you're a medical student, you meet the house officers, the junior registrars, the senior registrars, the consultants in the unit, and you'd ask them what they think should be in a preoperative checklist. To make it structured, you can design a questionnaire. Once you've gotten about 10 to 11 to 12 items that they have told you should be on the checklist, so you design a questionnaire, writing those 10 things, and putting check boxes on how important they think these things are to being in a preoperative checklist. And then you leave an open space for them to also add whatever they feel is necessary, and you share among all the senior members of the department. And after some time, you collect your questionnaires back, and once you have, let's say you have about 10 to 15 responses, from those responses, you can basically formulate the things that will be important before a patient goes for surgery. Once you've done that, the next will be to present your findings. So again, you approach the members of the team and the consultant or the HOD that, okay, you've completed the first part. You've identified the things that should be in a preoperative checklist, and you like to present. So let's say in a morbidity and mortality meeting, you present that, after your small percentage distribution, these are the things that would fit into a preoperative checklist, and you like everybody to start using this checklist. You send a pro forma of the checklist on WhatsApp groups. You print this pro forma and you place it in different wards. You place it in the nurses station, and you try to make sure that everybody in that department follows this preoperative checklist. After some time, maybe about 2 weeks to a month, you would want to do what is a sort of another cycle, in quotes, and then you would design a questionnaire to ask each of these each member of the team rather, on how beneficial the preoperative checklist has been, and what can be done to improve the preoperative checklist. If you've done your audit well, you should see some remarkable improvement in service, and that closes the loop. That means you have um, basically effected change in that department. When you're done, you can write up your findings and present it at conferences. There are conferences that request for oral and poster presentations, and you write it up, and you send it to those conferences, and you show them the practical change that you have made in that department. And if you've made this kind of change, there's a high chance that this change is going to be lifelong, and eventually it may even become an official document from the hospital. So a preoperative checklist that will be in every surgical patient's folder, so to say. Yeah. So that's the first practical idea that I believe we can do as medical students and medical career doctors um, in Nigeria. And this idea has taken us through the practical steps of conducting an audit. If you've been here for the last 3 sessions, you identify the problem, you conceive the idea, you build on the idea, you you collect data, you analyze data, and you present your findings. You recommend a change and ensure that the change is followed, and then you audit that change that you have sort of recommended to see if there's improved compliance, and then you do cycle and another cycle till it becomes permanent, or at least you've achieved a near perfect rate. So do we have any questions on this preoperative checklist before we move to the next one? Let me...
Any at this point?
Sorry, I didn't get that.
I said we don't seem to have any at this point. The chat box is empty.
Okay. All right, so we'll move on to the next practical audit idea. The next is establishment of guidelines. So this is more like a quality improvement project than an audit. In developed countries, there are guidelines for everything. There are standard protocols for everything. Patient has a seizure, there's a guideline that you follow. In Nigeria, this does not seem to be the case. There's a paucity of national guidelines, and ideally, guidelines are things that are developed from a backing of research, which can be quantitative and or qualitative. But guidelines can also be adapted from foreign sources, from developed countries. In some hospitals, you'd see that some of them have guidelines that they follow, and let's say in obstetrics and gynecology, there will be an established guideline, on board somewhere. That if there's a postpartum hemorrhage, you just follow this guideline, or if there's hyponatremia, you do this, do that, do this, do that. But a lot of hospitals do not have guidelines. A lot of departments do not have guidelines. So as a quality improvement project, in order to improve the quality of service, you can decide to make a guideline for your department for a particular topic. And the good thing is that you don't have to be too knowledgeable about that particular topic. You just have to conceive the idea and involve the consultant. So if you're trying to, for example, and a guideline on hypoglycemia, all you need to do is to meet the members of the endocrinology team and tell them, okay, you think a guideline would be beneficial in helping medical students, house officers, and any maybe corporate doctors, in practically managing, hypoglycemia. Just like the same way you did the preoperative checklist. Once you've gotten ideas from each and every member of the team, you create that guideline, and then you paste it in the department that everyone should follow this guideline. And then you can do a proper audit on the guideline that you formed. So a quality improvement project gives you the local guideline, but subsequent cycles will now be called an actual audit because you're auditing that particular guideline. Guidelines are numerous. You can establish guidelines for any and everything these days, especially when there's no established guideline as such in Nigeria like that. So making local guidelines can be things that you can do to improve quality. They still follow the same general idea, like the first one that I mentioned, and you have to involve members of the department, the head of department, and the most senior members of the team. You shouldn't be worried about approaching them, because you're not antagonizing them as such. You're coming to them as a young doctor with good ideas on how to improve service. So rather than emphasize the problem, you're actually preferring a form of solution to the issue. So establishment of guidelines is another practical idea that you can do. It's very, very cost effective. You don't have to spend so much. All you just need to do is to have a good working relationship with members of the team, approach them with the idea, and even some of them, once you write it up to submit at the conference, you can involve the names of some of these people as members of the audit, members of the team that conducted the audit, and they would also be appreciative of that. The third is anti-hypertensive guidelines. So I know I said that there are not many guidelines in Nigeria as such, but I'm aware that we do have some guidelines, particularly with management of hypertension. There are some guidelines regarding management of hypertension, but not many people follow those guidelines, as you might imagine. Private hospitals, teaching hospitals, they don't really follow guidelines, or even if they do follow guidelines, you have different people following different guidelines. People following JNT, people following some other ones, and stuff like that. So this can serve as where you come in. So if you've chosen, if you've seen that there's no particular guideline in your hospital, you can check up for the Nigerian Health System's guideline for managing hypertension and audit that and see how many people, how many newly diagnosed hypertensive patients are being placed on the proper medication. So once you've identified the guideline, so to say, the next thing is to arrange your methodology and all of that, and get your source of data. The kind of patients you use would be those that were newly diagnosed with hypertension, so to say. You can liaise with the information department of the hospital to get case notes, although it will be laborious. But in order to make for that, you can use just a small sample size, maybe about 30 to 40 case notes, and you go through them to see those that were newly diagnosed of hypertension, and then you check through the case notes and see what medications they were placed on. If they were placed on the proper medications, then that's good. But obviously, some of them will not be placed on proper medications as per the guidelines. And then you present your findings to the department that, okay, there were 40 new cases of hypertension diagnosed last month, but only 20% of them, only 20% of them had treatments that followed the Nigerian guidelines for managing hypertension. And then you emphasize that the department should follow the guideline for managing hypertension, and that serves as an audit. Or alternatively, if you don't find any guideline, or if the members of the team have a local guideline that they follow, you can establish the guideline as a form of quality improvement project, such that the guideline will now be official, pasted everywhere, and then you audit that. You audit their practice as against that guideline. I should mention here that audits can be retrospective or prospective. So it's not always that you have to go to the patient information records and pack all the cases and stuff. If you are in a unit and you attend, obviously you would likely attend. If I ask officer in a unit, you likely attend most of the clinics. You can look out for the new cases that are diagnosed. If it's hypertension, for example, you look out for the new hypertensive cases that are diagnosed in that clinic, and wait for the registrars or the senior registrars or the consultants to give their management plan, and then you take the case notes, and then you audit, what they have done, and then you fill it in your data collection book or Excel sheet or whatsoever. Sometimes prospective might be easier than retrospective, and this can be applied, in any specialty. Surgery, for instance, just think of any condition that is diagnosed regularly. Look for a guideline, audit it as against the guideline, and make a presentation. If there's no guideline, you establish a guideline with a quality improvement project, and then audit as against the guideline. So another practical, yeah. So let me pause there and take questions. Do we have any questions?
That if you have any question, type on the comments section. So I can invite you to just tell us your question.
If you have any questions at the time, type it. I would answer them. This is supposed to
But
be an
again,
interactive.
I understand unless you
session.
verify your account, you might not be able to type in the comment section. Let me see. Yeah, that's another issue. If you've not verified your account, you might find that difficult accessing the comment section to type. Okay, so I think we can do it this way. If you're unable to type your question in the comment section and you're on our teaching group, you can type it there. So I'll just note your name and then call you, invite you to the stage so you can tell us your question. I think that will be okay for those that can't access the comment section. But if you can, just type your question. I'll invite you to the stage.
Okay. So before we go to the final the final idea, so audits and quality improvement projects, all you need is an initiative, and it's not a big project really. It's very 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 simple and basic. It's one of the most basic cheap projects that you can undertake as a medical student, and you can involve a lot of people. You can come together as a group of 5 and identify a problem. I've given you practical examples that I can use. I just, whichever posting you are, try to identify an issue, or if there's no guideline or there's no established management of medical condition, or if you don't know the management of a surgical condition or medical condition, and you're not able to get a proper guideline from the department, you can seek to establish a guideline in that department by involving, members of the team, the senior registrars, and the consultants. And they're very, very, very happy. So the last idea that I'm sharing today. So these ideas are not limited. Okay, they're just I'm just showing you how we go from one step to another step to another step to another step up until we get to the end. And I hope that whatever ideas you come up with, this practical sessions have given you a fair idea of how to go about it in Nigeria. So the last idea is order documentation. It's important to mention that anything can be audited. Anything can be audited. If they can't be audited, then a quality improvement project can be done. There's really no limits to what you can do, and they're really, really important as medical doctors, even both in Nigeria and leaving the country. It's even more important in Nigeria because audits are the it's the most simple way that we can improve clinical service. So the last idea is ward round documentation. Like I said, anything can be audited. Many doctors in a department do not have a standardized way of documenting ward rounds. So you'd see that if 7 different members of a particular unit document for a patient, no, not admission now, not clerking, for example. I'm talking about actual ward round documentation, the daily ward round documentation by the team. You'd see that they're quite different. Everyone dictates in a different way. Everyone writes their word rounds in a certain way, and they're usually vastly different from each other. You can come up with an idea to improve quality with the same methods that I told you about. You meet members of the team and you ask them the things they feel should be in a daily word round documentation. You'd compile their ideas together, put it in a questionnaire, send it back to them, and let them tick which ones they think should be included, and also leave an open space for more ideas if they have. Once you've done that, you would present your findings that this, based on what all the department has said, these these are the things that should be in every daily ward round documentation. And then you send a performer through WhatsApp group, or you print the performer and place it at different points of the department, and encourage people, the house officers, the medical officers, to use this format when documenting daily ward rounds. You read it again to see how well they've complied with this. If there's good improvement, you can go to the management and sort of push for official documents. In a case notes, there are sheets that are used for documenting ward rounds normally. You can push that those sheets should have that already printed on each daily ward round documentation, and like that you've improved service to a very, 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 very high extent. And basically, anyone who gets into that department would not find it hard to write word rounds or to follow with whatever the department is doing. That's another practical idea that you can do with regards to word round documentation. Another one is operative notes. You realize that many surgeons have different ways of writing their operative notes. Although I'm aware that in many centers, though, there is an actual performer for writing operative notes. So that can serve as one. So if your center does not have a performer, with the same method that I've said, you can establish a performer for writing operative notes, and then audit to see how many people are actually following the performer. If there's an already established performer on your operative notes, for example, that in itself is a form of local guideline. So you can decide to go through all the operatives and see how many people are actually filling all parts of the operative notes. So for example, on operative notes, you might see like 9 to 10 subheadings, in an actual operating notes. But you see that most people don't fill all parts of the subheadings, maybe because they're lazy, or they're tired, or there's clinical pressures and stuff like that. So you can go to the information department, get about 20 to 30 case notes, check their operative notes, and see how many people are filling each aspect. And then, analyze the data and then present at the next mobility and mortality. And tell them that, see, a lot of people are filling, everybody feels the name of the anesthetist, everybody feels the name of the assistant surgeon, but only 50% of people are filling the operative findings. Only 23% of people are talking about the complications that have come up from surgery. And then you'd encourage people to fill as much as possible, the subheadings already on the operative notes. and then you re-audit again in a month to see if there has been an improvement, and then you re-audit again in another month to check if there has been an improvement. So those are practical ideas, really, that you can do as a medical student, early career doctor, registrar, consultant, whatever level you are in. Those are practical ideas. And like I said, every audit, no matter how small or large, can be submitted to international, national, and local conferences. And they would be recognized. And once they are presented at conferences, they can be published. Okay, so I believe we've come to the end of the practical ideas session. So the next one, I believe, will just be answering the questions that you might have with regards to any of these practical ideas. So I want you, the listeners, to think of any of the ideas that I've mentioned and the ones that you think you can do. And hold on, let me see. And try to think of the challenges that you might face, and sort of ask questions, and we'll see how we can navigate any of the challenges that you might have to starting a clinical audit. It's really cost effective. You don't have to spend, one kobo doing an audit, and that's the beauty of it. And you'd have improved service. Um, sorry, is the moderator around? Okay, so if you have any questions, please ask away in the chat box. Okay, how to go about the guideline auditing in the setting of a public university teaching hospital as a medical student. So the first thing you should do is identify the parts or the topic that does not have a guideline. You can check the notes that have been taught in class, the surgical conditions, check the management that the consultants have put at the end, then go to the department. Let's say you want to go to urology for management of benign prostatic hyperplasia. Then you go to the urology department and meet members of the team. They're usually about maybe 6 to 10, and ask each of them about that. Is there a local guideline for managing BPH? And if there is a local guideline, um, has it been published? So to say, published in the department. Is it in the offices? Is it in the clinics? And things like that. And that'll give you an idea of where you come from. If there's no guideline at all, then you ask them that. Okay, you begin to ask them how they manage, BPH, and you write it down somewhere. You ask each and every member of the urology department until you can draw a flow chart or a guideline. Then, depending, you can design a questionnaire now containing the stuff you've already written down, or on the flow charts that you think encompasses the management of BPH, and you share this questionnaire to all the members of the urology department and see whether they agree, with the flow chart and how well they agree with the flow chart. And you leave an open space to see if there are any changes, additions, or corrections. Once you get the results back, you would have a definite guideline. The next will be to present. So you get all the 6 to 10 people of the urology department together, maybe before clinics, and then you present your findings, introduction, how you did it, and that this is the guideline that everybody has agreed upon. Once you get their blessings, you just simply print. Maybe you make it colorful, and you print the guideline, and then you paste it on in the offices. You send it to their WhatsApp groups. Hell, maybe even send it to your classmates as well, and that has served as a proper quality improvement project / audit. Does that answer your question? So considering the hierarchy in place, so you're not going with the mindset of you are the boss or whatever, which is why the first thing is to meet the most senior head of the department and tell him about your idea and what you intend to do, and how this is a project that you want to work on, and they will support you. You can add that you would like to also present this at the national conferences, and you like them to also be the supervisors. So you can make the HOD your consultant supervisor on the project. You can make the chief registrar in the unit, the chief supervising registrar of that particular project, and you make it about improving the units. And it's not like you're coming to change things. You're coming to help them improve the units using their own ideas. And I'm sure nobody is going to, nobody's going to be hostile enough to turn you down. And if they turn you down, you just try to think of another idea in another department. Unfortunately, um, everyone will not be nice. But depending on how you approach, you can. No one is too young to do an audit, career-wise. Anyway, so yeah, that's it. Um, do we have any other audits done in private hospitals recognized? Yes, audits done anywhere in the healthcare setting is recognized. The aim of an audit is to improve service. That's it. Once you can show that you have improved service, whether private, public, tertiary, secondary, primary healthcare center, comprehensive healthcare center, once you can show that you've improved service delivery with regards to patient care, it will be recognized anywhere in the world because it means you're contributing in a way to service improvement, and which is one of the things that we are really lacking in Nigeria. We always talk about the problems, but nobody really comes with the solution. And here you are coming with an idea to improve service in your own little capacity. So yeah, it will be recognized anywhere in the world. So do we have it? It was like there's a new message. Okay. Do we have any other questions? Um, I'm strong. I think it's over to you now.
That question, but let me still check. Okay, yeah, we don't have any other one. You've answered majority of the questions, and I think. Do you have any other thing you would like to share with us, or we can come to an end?
Um, yeah, I would just like to encourage everyone to start conceiving the idea for an audit. At least at the end of this session, you would have gone through 4 sessions on how to conduct clinical audits. And the next best thing is to put it into practice. So you can get a team of 5 and decide on a really small audit or quality improvement project that you can do. And all you have to do is really to start the first one. Once you've done the first one and you've seen the change that it does, you'll be motivated to do more. And once you've presented at conferences and you've seen the positive feedback that people have given, it's going to motivate you and give you good skill in your career onwards. And if you decide to apply for foreign exams or to work outside the country, they would be beneficial. These different audits that you have done would come in handy with giving you an edge um, over people who have not done audits or who have not made any efforts to try to improve service. Yeah, thank you. Yeah. Okay, so I would like to encourage everyone to also provide feedback. The feedback forms are in the comment section. The feedback forms are the only way. It's the only way that you can get a certificate. So once you fill the feedback form, the certificate will be generated, and you'd have that as an evidence that you've attended the first official teaching project from SIGAF. and we would hope to do more teaching projects with regards to other things like research, teaching, more audits, and more projects that we believe early career doctors and students can benefit from. Um, thank you very much.
So, like he said, it literally goes down to you just thinking of any topic at all that you want to write an audit from, and he has highlighted a few that could be easy. Last week Friday we talked about management of something around DVT, like just prophylaxis for DVT in patients that you know will be immobilized for a long period of time. And then today, like hypertension, which is quite common, you can easily have access to a good number of patients with that in your hospital. So, and then aside that, will still also be available in case you still want to, if you come up with an idea and you're not so clear about how to go about it, you can always message any of us and we'll see how we can put you through. And then I've shared the feedback form. Currently, it's in the chat box. If somebody is asking, but I've shared it already, so you can check. Just check the chat box messages, you'll see it there. Just click on the feedback. It will generate your certificate automatically. Onyekachi is asking, I don't know, just scroll up, you'll see it. It's just above Damilare's comments. So you just fill it and it will generate your certificate immediately. So this will bring us to the end of this series and today's session. I want to thank everybody for joining us. We have many other programs of this nature that we are working on, and we'll always share the link and you can join us because it's definitely going to profit you, your career, and then your own growth as a clinician. So we'll see you guys in the next session. For now, it will be a goodbye from us. Okay, somebody is asking a question. Please, can we have access to the various resources used by the trainers? Oh yes, we've been sending some. We sent the first two on the general group chat. That's the group chat for the teaching sessions. So we'll be share. This particular one is just one slide that Dami sent, but I'll still post it on the group chat also. So that'll be all for now. See you guys some other time. Thank you very much. Have a wonderful weekend. Please ensure you fill the feedback form. If not, you'll not get certificate.